This is week 1 lecture, Communication and Collaboration. And when I go through this week 1 lecture, I'm going to do it slightly differently by showing you the slides with the notes on them so that you are able to navigate the next 4 weeks lecture slides and know where the notes are for you to understand each slide. So right now I'm just going to go through the week 1 lecture, and I'm going to lecture as if we were in class, talking about the notes that I would be discussing with you if we were face to face. However, this will be the last lecture that I actually record and present in video format. For weeks 2, 3, 4, and 5, you will have lecture PowerPoint content every week to view and learn on your own. And there will be notes at the bottom of most of the PowerPoint slides to enhance your learning on what the content is on each PowerPoint slide. But I will not be doing lecturing in a video format at that point. You will just be learning on your own by clicking through each one of the PowerPoints and reading the additional notes on the bottom. So technically, you'll be doing a lot of this concept-based learning on your own. I just wanted to do this first week's lecture and just kind of show you the idea of how we would work through this. So you would click on your first slide and it would say Communication and Collaboration. The second slide, we talk about the definition of communication. And this is a definition from Gideon's. And it's the process of interaction between people in which symbols are used to create, exchange, and interpret messages about ideas, emotions, and mind states. So we need this to provide accurate, appropriate, and timely sharing of information. It's the key to team relationships, and it's the key to patient safety. Miscommunication is the leading cause of medical errors. When we talk about the communication process, we talk about the basic process of communication. Now notice down here there are notes. So normally if we were face-to-face, I would be doing some sort of elaborative version of these notes and we would have a discussion on this. Since we won't be doing that, I will leave the notes there, but you'll be reading these to enhance what's on the PowerPoint slides. So in this basic process of communication, we talk about the need for information and how the sender sends message through verbal, spoken words or written, or nonverbal communication like gestures, eye contact, and touch. So this is very important that we understand that when the receiver interprets the meaning of messages or responds, that we have to understand that there might be other things they need to filter through, such as past experiences, culture, mood or attitude, or outside noise or distractions. The factors that affect communication can obstruct or distort the communication we're trying to get across to our patients. So communications with patients can be deterred or interfered with things such as the patient's in pain, they're sleep deprived, their knowledge level is low. A lot of our information that we print on medical pamphlets, we usually try to avoid heavy or complicated medical jargon, as well as keeping it at about a 6th to 8th grade level, so it's more universal across the board. Once communication exchange has occurred, the receiver will provide feedback. Example in healthcare is regarding communication and feedback is what we call the teach-back method. So we need to understand that the patient or the receiver of the information understands the information we're giving them. So we do something called teach-back, and it's a way of checking understanding by asking patients to state in their own words what they need to know or what do they know about their own health, about the instructions we're giving them, the directions, their medication, signs and symptoms to look for. It's a way for us to confirm their understanding of all this information. And we do this a lot when we talk about discharge instructions from hospitals or from outpatient settings. When we talk about nonverbal communication, we're talking about body language, facial expression, gestures, eye contact, touch, and keep in mind that these can be influenced by culture, not only in certain cultures how we do certain things or in certain cultures how that's interpreted. So just be aware of our own personal nonverbal communication as well. So body language can show emotions that infer that we are listening by leaning forward or that we're interested, or it could show that we're disinterested or are short with them by maybe having our arms crossed. when we talk about gestures, we're talking about being careful that we're not overusing our hands, and keep in mind that this is where culture can play a role, that different gesturing of hands can mean different things, such as a handshake for a greeting. Eye contact is another one that is very culturally sensitive. Some cultures want to see eye contact to know that you are involved and engaged, whereas other cultures might find this as a sign of disrespect. Touch is a big one, and that's a big one for nonverbal communication. Touch can convey the caring, and it's the case of what nurses do all the time, holding hands, telling the patient that you're there for them, possibly rubbing their back if they're in pain, letting them know that you're there for them. But it's important that before we touch that we know boundaries. It's important that we communicate to our patients what we're about to do. So for instance, if I'm about to palpate or feel their belly, I might say, okay, I'm going to go ahead and touch your belly now. This might be a little painful. Just go ahead and lie flat. This is what I'm doing. I'm explaining to them what I'm doing before I touch, and it makes the patient a little bit more comfortable with what's about to happen. With active listening techniques, we want to use things like being silent and allowing the speaker to have time to organize their thoughts. Sometimes offering general leads, specifically when a patient's not even sure where to go from there. We want to make sure that we're always using an accepting, non-judgmental attitude. We want to make sure that the patient can restate in their own words what we just told them so we understand that they understand correctly. We're going to reflect on what the person said, and we're going to have them have time to reflect so they can process this information in their own answers. We want to focus in calling attention to certain points, especially events of importance. We want to make sure that we're exploring or examining different ideas or experiences. We want to make sure the patient feels comfortable to seek clarification, so to attempt to clearly understanding the meaning of the person's statement. And not only the patient, but we may hear something from the patient that we need to seek clarification of. Maybe we have a misunderstanding of what they're saying. And then we need to make sure that we can verbalize the implied. So if a patient is implying something, we might want to put that into words. So what you're saying is, and we put it into words so that we, again, understand what they're focused on and what their understanding is. Communication and nursing practice go hand in hand. It is the key to a good nurse-patient relationship. Patient safety requires that there's effective communication, and we want to make sure that we always are improving patients' outcome and increasing their satisfaction with good communication. So we want to make sure we're communicating with our patients and their families. We want to develop a trusting relationship. We want to understand that miscommunication can lead to medical errors or unsafe practices. And we always want to make sure that we're practicing and our communication skills within the confines of our professional practice, and we're meeting legal, ethical, and clinical standards of care. There are different examples of communication in nursing: assertive, therapeutic, interpersonal, electronic health record or documentation, and handoff reporting. So in assertive communication, we want to make sure that there's positive and negative ideas that are expressed in a very direct way. We want to make sure that a patient can be open and honest with them, and that they don't have fears about misunderstanding or miscommunication. We want to make sure we're the patient's advocate. So often asking the patient, do you understand my instructions? Are you comfortable with the plan of care that your doctor has put in place? And we're always making sure that when they do communicate with us, if they're uncomfortable with something or they don't understand something, that not only do we answer their questions, but we bring that back to the doctors, physicians, or other healthcare workers who are ordering these plan of care so that they understand where the patient's at. We're their advocate. We're their communication between them and the doctors in most cases. Also remembering that therapeutic communication between the nurse and the patient can actually help the patient overcome stress and sometimes overcome those psychological blocks that they have. And it really is the key to how we build our trusting relationship with them. In intrapersonal communication, this is where we're doing self-talk, where people's thoughts and inner communications are strongly influenced by, again, perceptions, feelings, behavior. And interpersonal communication is that one-on-one interaction we have with a nurse and another person when we come face-to-face specifically. And this is really important when we talk about intraprofessional collaboration, where we're coming together as a group to really communicate and decide for what's best for that patient. As far as that goes, we do a multidisciplinary approach. We communicate with doctors, therapists, nutritionists, specialists. We do consultations. Everyone as a whole comes together for one specific goal in mind, and that is to care for the patient and to do what's best for them. In electronic communication, we talk about this in documentation, in computerized healthcare records. So technology creates this ongoing patient care as well as communication within the whole healthcare team. And we're very careful to make sure that these messages are secured and that they're protected. So we have something called HIPAA, HIPAA, and this stands for the Health Insurance Portability and Accountability Act. And these were laws that were designed to provide privacy standards to protect patients' medical records and their health information provided to insurance companies or doctors, hospitals, etc. So we want to make sure that all that communication is well protected and the patient doesn't have to worry about their information getting out when they don't need it to be, or for people who don't have an interest in their care and seeing it. One of the key types of communication we use in nursing is called SBAR. And actually it's used throughout healthcare. Doctors use it as well. And it's a framework for team members to effectively communicate to one another, basically the plan of care. So it communicates the following: the situation, what is going on with the patient; the background, what is their clinical background or the context of why they're being seen by a physician or a nurse; the assessment, what is actually going on, what's the observation I see right now or the problem with the patient; and then the last thing is the recommendation. What do we recommend that we do for this? So nurses might use this when they communicate with a doctor via phone or when they want to get orders from the doctor. They may say something like, I notice the patient has this signs and symptoms or this vital sign. They are here because they have this specific disease. What I'm seeing or assessing or observing is this, this, and this. And what I recommend, and then I would recommend possibly a medication order or a test to be done or a lab to be drawn. So we use this SBAR in that type of form of communication a lot when we're speaking with doctors and when we're trying to obtain orders. But doctors also use it within their physician notes to let the next doctor know who's coming on, maybe another resident or an attending doctor, maybe another consult doctor that's coming in, a specialist, so they understand where they're coming from the last time a physician saw this patient and what the recommendation is and where they go from there. It's always important to remember that effective teamwork is the foundation of that interprofessional collaboration. And it does significantly reduce medical errors if we're all on the same page. And a lot of teamwork involves clear roles, simple objectives, decision-making ability, rewarding performance, dealing with problems as they arise, accountability per all the team members, and then team-building activities. Team is defined as a group with a specific task or tasks that they're trying to accomplish. And we want to make sure that this team has shared responsibility for the decision-making, the planning, the delivery of care, and the accountability if something does not go as planned. We want to make sure that there's clear objectives that they're following, that there are different multidisciplinary teams, so different members of different areas of the hospital, of the healthcare environment, working together for a common goal. And our goal is always patient care and patient satisfaction. There are different communication styles when we refer to leadership. And leadership is the ability to coordinate the activities of those interdisciplinary team members by ensuring team actions are understood and that there's changes of information that are being informed and shared and that team members have the necessary resources to do this. There are different types of team leadership: authoritarian, shared leadership style, and transformational leadership. Authoritarian leaders are ones that are in charge, and there really isn't a lot of place for this type of leadership in medicine. The only time I could think where this would really work is when you're doing like a code, a CPR or resuscitation. You do need a clear leader who's running the code, and everybody else needs to kind of fall in line with their jobs. You don't want too many people shouting out directions and orders. It really should just be one person. But for the most part, I would say healthcare has a shared leadership style where leaders engage team members